Hey everyone, what is going on? My name is Michelle and I'm one of the admins of Outpatient OT. So I want to welcome all of our new members here real quick. And so I'm popping in for that. So welcome to Outpatient OT. This is an active group, or at least I hope it will be. And the point of it is to rethink OT, rethink the way we do things, rethink the way it's currently being perceived, because the perception of the way OT is that we are harnessed, we are closed, we are locked into this ADL square. And so how can we get out of that? And it's all about how we're approaching our day-to-day practice. And so I am sharing what I do. I own an outpatient occupational therapy adult clinic, and we mainly treat neurological rehabilitation, but we also treat a lot of geriatric, do a lot of geriatric rehabilitation, and then ortho as well. So today, along with saying hello, is number one, please let me know if you can hear me, because I'm having some issues with my sound. So let me know if you can hear me. That would be fantastic. Just put like a thumbs up or like a number one in the comments if you can hear me. That would really help me out. I appreciate that. And we'll just push forward. So what I'm going to be talking to you about today is new considerations for a new patient. So if you're an occupational therapy practitioner and you're either about to see a new eval, or maybe you're about to just in general see a patient for the first time, what are you looking at? Because whether or not you're an occupational therapist, although OTRs will perform the initial assessments and go through the evaluation process, that doesn't mean that a certified occupational therapy assistant is outside of that assessment purview, because you as a COTA can perform just as many assessments as an OTR. You still have a critical lens. You just do so in collaboration with the registered occupational therapist. So thank you very much for the thumbs up, Hannah. So my sound is working just fine, and I appreciate that. So this great divide between OT versus COTA, and COTA is not getting a lot of respect, is ridiculous, because we're two sides of the same coin. We need both sides, the OTR and the COTA, to provide a very efficient and full and robust and effective plan of care. So let's nip that in the bud. This is for both of you, whether you're an evaluating therapist or you are a certified occupational therapy assistant. This is relevant information for you. So top three considerations. Number one is, and I apologize, I didn't write these beforehand. So number one is perception. What do I look at? So number one, the beauty of occupational therapy is that we think about the perception of somebody, and we know that it directly impacts physical outcomes, because unless your patient is on level playing field with you, unless they're buying into the process, we know that there's this great chasm, there's this great divide between where the patient is and where we know they can get. And it's perception. That's what's connecting those two things. So what am I talking about with perception? Well, first and foremost, it's how is the patient perceiving their barriers? What is going on with the patient in relation to their diagnosis, which you need to know the diagnosis first and foremost. What is their relationship with that diagnosis and their prognosis? What's their perception on their limitations, what they're facing? So what is being impacted in their daily life, and how is that making them feel? Much like COPM, right? That is what we use that for, or you can just have a discussion with them. A conversation works just as well. So when we think about perception, we want to identify the patient's perception of their altered abilities or whatever they're going through, whatever scope you are looking through. So that's number one. Number two is their perception on the occupational therapy profession. What do they know about what you're about to, about your lens? What do they know about occupational therapy? Do they know what you do? Do they have a misguided idea of what you do? Maybe they think, which is what happens to me a lot, maybe they think that all you do is ADLs. Maybe they're sitting down with you and they're not even listening to what you're saying because they already think you're irrelevant. So you need to address that elephant in the room, right? You need to say, hey, have you ever seen an occupational therapy practitioner before? Have you ever done occupational therapy? What do you think that we do? Or how do you think I'm going to be able to help you with this? And then they're going to tell you, or they're going to say, I really don't know. And then you're going to have the opportunity to explain to them what your lens is, how that's relevant to them. So perception of their own barriers, and then perception of OT. That is huge. You have got to define that before you begin a plan of care. And thirdly, what's their perception on your plan of care? Discuss that with them. You cannot just make their goals for them, put it in a computer, send it off to a doctor, and begin and give them activities. You can't just do that. You have got to discuss it with them. That is part of the process. We dismiss that so much, and their perception on your plan of care and their perception on their goals that you have set for them to achieve is crucial to independence. And remediation and rehabilitation, if they're not buying in to how you plan on helping them, on helping restore their function, then there's no point. Occupational therapy is client-centered, which means you have to get their thoughts on your plan of care. Hey, Mrs. Smith, you've just had a stroke, and this is what OT is. And you know what? These are some goals I think we can really achieve. And I think it's going to be really great. And these are some ways that we're going to achieve these goals. What do you think about that? Would you change anything? Does what I'm saying make sense? Or does it seem silly? Does it seem irrelevant? What do you want to work on? If you could change anything, what would you change about that? That conversation is very, very important. So discussing the perception of the plan of care. Okay, so the second thing that I really hone in on is, this is going to surprise all of you, occupation. What is being affected? So we've discussed perception and we know the diagnosis, and we've already done our homework. We know the physiological components of healing for this diagnosis, and we know how we're going to leverage certain elements within the plan of care. Now let's discuss occupation, build the occupational profile, and learn what is actually being impacted for this person, as well as what do they want to get back to doing. Now, occupation, this is where activity analysis comes into play. Think about what they're telling you. Think about their deficits that you've already listed in that objective section of your report. Think about all of the symptoms that they're experiencing. Think about all of the barriers they've defined already. And then in your head, you need to have already done activity analysis on those major occupations and activities. Because, for example, I have a client who just had a bilateral carpal tunnel release, okay? Another client, actually, this is probably more pertinent. I have another client who just had 3 trigger finger release surgeries, and she's having a lot of generalized weakness. And although her range of motion is really within functional limits, that strengthening really needs to come about. Now, I needed to ask her, I said, what's being affected? And she's like, I'm really having a hard time doing the spray butter, doing cans. And she went on to list all of these things. And I was like, oh, I knew that she was having pronation and supination issues. I knew that radial ulnar deviation was a challenge and was painful for her. And so I had to ask her, And how is it, how are you doing putting on a bra? Like, how is that going for you? And she's like, you know what? It is so difficult. I really can't do it. I just wear tank tops because I really can't do that. She would have never asked me that. I needed to ask her. So I already needed to have an established arsenal of activities that I've already done an analysis on, because this, and this is being affected. I know it's going to directly relate to these activities and it's going to impact them. So I'm going to ask the client about it. So defining what occupations are being impacted so that we can keep that lens, the entire plan of care, is crucial. And then lastly, foundation. So the last thing I look at is the foundation. You know that I've already discussed with you how important I believe the biomechanical model is. Biomechanical, kinesiology, biopsychosocial, those frames of mind are crucial to being an occupational therapy practitioner, because everything comes from movement. We're not activity leaders. That's not what we are. We are not activity leaders. I love activity directors. I love activity leaders. Occupational therapy absolutely has a role in working with activity leaders, or even finding themselves in that role. But if you're in the clinical side of occupational therapy, that's not what you're doing. That's a separate job description. That's a separate pay scale. What you're doing, what you're licensed to do, is medical. It's medical related. So you need to lead with that, and therefore we need objective measurements about the science of the body. So what do we need objective measures on? Many of my patients, despite their diagnosis, I will do a cognitive assessment, a quick cognitive screen, because I need to know where they're at. Are they going to be receptive to what I'm telling them? What is their level of that like health literacy? How am I going to best communicate ideas to them? Are they going to be able to retain the information that I'm giving them? If I give them a home exercise program, are they going to be able to carry that over safely because they remember what it is I'm telling them? Or are they at risk for losing that information, and therefore when they get home, my home exercise program could actually injure them? So many of my patients, depending on their diagnosis and a few other factors, they will all receive a cognition screen, because it's going to best help me manage their therapy, their remediation journey. So cognition. Next, range of motion and strength. And this is for, so for hand therapy, obviously, you're not going to test their lower body strength and range of motion. That's not what you're going to do. That's irrelevant. But if it's anything else, like CVA or TBI or generalized weakness, or, cardiopulmonary deficiencies, whatever it might be, that's a whole body thing, and therefore it's going to affect the entire body. Your occupational therapy, which means you don't parse the body, you're holistic. You have to address the needs of the whole body. That is your purview. That is what you must do, because that's your scope of practice. So we can't just take measurements of the upper body and call it a day. We have to look at how their diagnosis or their issues are affecting their entire body. So you're going to take range of motion measurements on the upper body. You're going to take range of motion measurements on the lower body. If they're within functional limits, obviously you're not going to capture those specific measurements. You're just going to say within functional limits. But you're also going to do a quick manual muscle screen, just a real quick one on all big muscles of the upper and lower body, so that you have an understanding of where they're at. The next is going to be posture. Posture, all movement stems from posture, so we're going to address that. We're going to write that in the inspection part of our eval, so that we know how their postural alignment is, which leads me to alignment. How is their muscle alignment? Do they have any malalignments regarding their bilateral upper extremity, their scaps, right? Their pelvis? How's their gait? Do a gait assessment. So the next part is that functional ambulation and transfers. You need to address that. Those are huge components of any occupation. anything that they're going to say involves walking and balance and transfers. That is important for us to address. So what are the biggest things that you're going to address for most clients? Perception, occupation, and building the foundation. As an occupational therapy practitioner, you're helping them rebuild themselves, right? Much like a contractor is going to rebuild a home. They're going to buy it, you know, it's been kind of run down, you know, it's been through a lot. What are they going to work on first? They are not going to work on painting. They're not going to get their paintbrush and quick make it look pretty. They're not going to do that. They're first going to go downstairs to the sub-level, and they're going to make sure that that foundation is on point. So we have to start with that foundation, and therefore the last part of what you should be looking at is F, foundation. Okay, so that's it for me. I just want to drop in and share that because that's like a mentality that I apply to most patients that I see. And sometimes I'm breaking that down every treatment as well. It just helps me to kind of guide myself through each person's track, if you will. All right, that's it for me. If you have any questions, please let me know. Otherwise, kinesiology starts next Wednesday. Let me know if you have any questions regarding that. I'm excited to share some ideas with you, and I hope you have a fantastic week. Bye.